What are IDDs? IDDs are intellectual and or developmental disorders that are chronic lifelong conditions that affect the physical, intellectual, and emotional development of a person. Some examples of this include autism, Down syndrome, cerebral palsy, and fetal alcohol syndrome. This can affect a multitude of factors such as learning, reasoning, social skills, and daily activities throughout the duration of someone's life. And throughout this presentation, we'll be looking at how IDDs affect long-term aging and what the goals of aging are in that aspect, what the likelihood and effects of abuse on people with IDDs are and how they can affect them, some behavioral challenges that they will go through throughout their life and how people will help to support them, and two additional questions at the bottom that can answer some more questions about IDDs.
Historically, individuals with intellectual and developmental disabilities had a shorter life expectancy than the general population. However, advances in healthcare have led to longer lifespans, and many people with IDD are now aging into older adulthood. Life expectancy varies, with individuals with more severe IDD or Down syndrome often living into their mid 50s, while those with mild to moderate IDD may live into their early 70s. As they age, individuals with IDD experience many of the same health conditions as the general aging population, such as cardiovascular disease, diabetes, and arthritis, but these conditions often occur earlier. They are also more likely to experience declines in hearing, vision, and cognitive functioning, as well as an increased risk for dementia. The goals of individuals aging with IDD are very similar to those of other aging adults. These include remaining as independent as possible, maintaining physical and mental health, staying socially connected, and continuing to participate in their communities. However, achieving these goals can be more challenging due to limited access to healthcare, fewer financial and social resources, and less participation in health promotion activities earlier in life. Loneliness and social isolation are also significant concerns, especially for individuals who rely on aging family members for support. Because of this, person-centered planning is essential. Strategies such as supported decision-making, self-determination, and advanced care planning ensure that individuals with IDD are actively involved in decisions about their life and future, and that their preferences and values are respected.
Hi, my name is Sabrina. I'm a PA student. I'm going to be talking about abuse. So, individuals with IDDs are 4 to 10 times more likely to experience abuse than those without it. And abuse can present in a multitude of different forms, ranging from physical, sexual, emotional, exploitation, neglect. That's really just touching on the surface of the types of abuse that can be found in this patient population, but we see that sexual abuse is the most common type of abuse this population experiences. And the abuse is more oftentimes somebody that they know and a repeated offender, meaning that this is happening by the same person more than once. And this population also experiences abuse for an extended period of time due to different barriers. So the first barrier I'm going to discuss is a dependent situation with their abuser. So a lot of times people with IDDs depend on their abuser or someone else for financial support, transportation, housing, food, emotional support. And sometimes people with IDDs can have difficulty communicating, whether that be communicating to somebody else to ask for help or communicating with their abuser and standing up for themselves or recognizing that something is wrong. Communicating their feelings and expressing their feelings is something that we see present in this patient population, so that can be another barrier that elongates the abuse. And lastly, this population sometimes can have limited access to social services, health professionals, and law enforcement, whether that be because of the dependent situation of their abuser or their difficulty communicating, or just not knowing that these resources are available and here for them to help them for just people in general in this situation. Alrighty, moving into the next part. So what can we do as clinicians to recognize abuse? So with abuse, there is an emotional and psychological impact on the person being abused. So a lot of these people feel guilty, they have decreased self-worth, they are have increasing distrust and fear of others just because of their personal history with another person being abused. And trauma may also even present in these people without even us knowing. So there might be something that, as a clinician says or does, that can be traumatic for a person, and we didn't even know or realize that that would have been traumatic for them. So it's important for us to recognize abuse as clinicians and what are signs that would lead us to think, hey, this person may be being abused. So cognitive effects such as like difficulty learning new skills, somebody can't process information, loss or decline in communication abilities, physiological being frequent headaches, abdominal pain, sleep changes, disturbances, so sleeping too much or not sleeping at all, maybe loss of previous gained developmental skills. So if somebody's just not acting like themselves anymore, something even like bedwetting can be a signal that something else is going on, and this person is experiencing that because there's something underlying causing that. And then behavioral effects, so such as somebody being very aggressive or irritable, maybe a lot of excessive screaming, crying, maybe somebody being fearful of anyone in every situation, and just a regression in somebody's behavior in general can maybe be a sign that there's some abuse going on here. So what can we do? As healthcare professionals, it is vital to be very, very purposeful of our actions. So avoiding touch when we don't need to, being mindful of our tone, our body posture, our body habitus. How are we speaking to somebody? And are we being friendly? Are we making eye contact? Are we eye level with them? And then always explaining what we're doing, why, asking for consent before we do anything, especially when we are to be touching somebody else. And we want to just build rapport. We want to build trust. We want to make sure this person understands that they're safe in our environment. And just using trauma-informed care can help us take care of these people and not trigger them in a way and make them trust us and trust healthcare professionals as a whole.
Challenging behaviors can present when an individual with IDD has needs that are not being met. So, this is often seen in individuals that have limited communication. Some examples of these challenging behaviors are verbal or physical aggression, breaking or damaging objects, screaming, or scratching oneself. So, what would intervention or management look like for someone with IDD? So, this can include a variety of things, such as reducing the environmental stressors, um, remove known triggers, promote comfort and sense of safety, and then use individualized communication strategies. And we want to avoid anything such as punishments, restraints, or seclusions. This takes away the person's autonomy.
To wrap up our presentation, we've come up with 2 additional questions about IDDs. The first one is, what are some prophylactic measurements that you could take to stop comorbidities before they happen? For a person with IDD, or if you're taking care of someone with an IDD, getting regular physical screenings of their health, as well as encouraging physical activity, improving nutrition, and managing stress by doing fun activities, can all help to stop comorbidities before they occur. The second question we've come up with is, in what ways can a healthcare team caring for a patient with IDD communicate or work together to make sure that there are not secondary conditions going unnoticed? For instance, if a PA notices a physical or behavioral change that can be addressed by an OT, how can they ensure this finding be relayed to the treating OT rather than being looked over in the SOAP notes? So by having a short meeting about patients with IDDs to discuss concerns or changes that they've been noticing, can be more direct in helping the patient in their long-term health. Furthermore, when talking directly to the person, in this case the OT, about what concerns that they may have, uh, it can result in a joint evaluation, meaning that both members can work together at the same time to resolve the problem with the patient or resolve any changes that may have occurred with the patient that can prevent secondary conditions from going unnoticed.